This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
There were some requests to do a medical minute on some critical care medications. So I thought it'd be smart to talk about some of those. And when I think of critical care meds, I think of them broadly in buckets of vasopressors, maybe sedation meds, and then paralytics. So those are broadly speaking. I mean, you can go into more nuances there in terms of anticoagulation reversal or other cardiac meds. But broadly speaking, those are three buckets. Does anyone know how we can think about different vasopressors that we use and indications for using one over another? A good way to think about it is just what are the receptors that they're activating and what our goals are. So I think about our vasoactive medications in terms of three categories. We've got our Inopressors, meaning you get increased cardiac contractility and peripheral vasoconstriction. Then you have just pure vasoconstrictors. And then we also have inodilators, so you get cardiac contractility and vasodilation. Do you know any meds in these categories? What would be our go-to Inopressor? Something that causes contractility and causes peripheral vasoconstriction. Yeah, so Epinephrine is a perfect example of that, right? We have both beta and alpha activation, and you're going to get more beta than alpha, so it's really a strong inotrope. Another one. Yeah, exactly. So Levophed, so the norepinephrine is the generic name. That one you have more vasoconstriction peripherally, then you get inotropy. So you're going to get a little bit more peripheral vascular constriction, then you're going to get contractility. And then moving into our class of just peripheral, what would be a good peripheral vasoconstrictor? So that would be phenylephrine, right? That one is just like pure alpha. Does anyone know another one? Another really good option there is a Vasopressin. So that one you just activate V1, V2 peripherally. You get essentially no cardiac contractility, and it's just purely peripheral vasoconstriction. And then our inodilators. Do you guys know what are... There's a couple of them, but there's really two that come to my mind right off the bat are inodilators. Yeah, exactly. So dobutamine is one. And then there's one other famous one that we talk about every now and again. It's milrinone. These are meds that we usually aren't starting initially in the ER, but theoretically they're really good for conditions like cardiogenic shock. But oftentimes in the emergency department, we have honestly more undifferentiated shock. And so when we have undifferentiated shock, our go-to vasopressor is going to be norepinephrine. It's been studied as an excellent medication in multiple different forms of shock, specifically septic shock and cardiogenic shock. So when you're thinking about a vasoactive agent to use, norepinephrine is our go-to. I think of a couple of cases where you need to switch to different agents. So if you have a patient who's crashing atrial fibrillation, do you know what my go-to vasoactive agent would be? And there's a good reason why. So you'd want to do an agent that does not have a lot of beta activity because their heart is fibrillating and they're hemodynamically unstable. You don't want to be activating the heart anymore. So that's when phenylephrine is a really excellent choice because you don't want any beta activity. You want pure alpha. You just want them to clamp down a bit. So phenylephrine is a great choice for that. Phenylephrine is also really good for when you have post-intubation hypotension because it's mainly from just all the meds you gave and they're just vasoplegic, so they're just peripherally dilated. So let's just counteract that right away. Let's just give them some peripheral squeeze and that'll kind of turn that around. So those are some kind of edge cases where you just want to use phenylephrine as your go-to agent. But again, norepi is my go-to for most cases of shock. And then if I'm really confident that it's purely from the heart and we don't need to worry about dropping their pressure too much or anything like that, then epinephrine is an agent that I might throw into the mix. I'd consider adding on dobutamine or milrinone with cardiology consultation because those are more nuanced medications. But we don't need to go into other meds. We can talk about those at another medical minute, but just as far as a quick overview of vasopressors, that's kind of my go-to agents and how I think about them.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, Please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.